breakfast symposium. So brunch will be served, and inshallah, we hope to be finished around 1 p.m. We will send out more information, but I just wanted to bring everyone's attention to that. So without wasting too much extra time, let me just take this opportunity to welcome Dr. Sandeep Bana. We really are very honored to have you here, a true expert in this field and the current head of the Department of Endocrinology and Metabolism at the Chris Hani Barrow Hospital. Dr. Bana, I have the privilege of getting some of your CV to prepare to introduce you today. Unfortunately, if I go through all your achievements, it's probably going to take us longer than the actual symposium.
No, so, please don't. So it's just I work at Barrow. I think that's.
I work at Barrow is really underplaying your role. Like I said, the current head of the Division of Metabolism and Endocrinology at Barrow. He's also had various senior roles in the Department of Health Sciences at the university. He stepped in as acting head before in this department, as well as various internal medicine wards. Ward 21, Ward 22, a certificate in endocrinology, currently a PhD candidate. And we really look forward to learning from you on this very relevant and important topic. I'm not going to go through all your publications and everything. There's quite an extensive list here, but welcome, Dr. Bana, and thank you again for availing yourself to speak to us. And yeah, handing it over to you.
Thank you very much, my dear. And thank you for inviting me. Now, the field of obesity is quite big, and I've been asked to talk to you guys on the impact of obesity on health, which is an important topic. Some other topics are looking at the pathophysiology behind obesity. Some of the others are looking at the pharmacotherapy. So there's various aspects, but I think it's a good place to start. So can you guys see the screen? Yep. Okay.
Yes, your screen's been shared perfectly. We can see it.
Just wondering why it's not moving forward. Okay, perfect. So these are my disclosures. And so let's start by first emphasizing that obesity is recognized as a disease, and it's definitely a health epidemic. Now, that's important to emphasize from the beginning, because for a long time, this has been just viewed as something that was just phenotypically an issue to people in society, and it was a cosmetic problem. However, you'll see these are just 6 out of many associations that have already recognized this as a problem. So if you look at the World Obesity Federation on the top left, they're taking the position that it is a chronic relapsing progressive disease, and they emphasizing the need for action to prevent and control, which is now an epidemic. If you look at the American Medical Association, they're saying the same thing as well. The UK, same impact. And so we can just go on and on. The important factor is that it is now a medical condition. It is recognized by most funders world over as a condition, and in most countries it has an ICD-10 code as well. So if there's a condition, you need to be able to define it, and there must be a way of classification. I mean, that's how we are wired as doctors. So obesity is defined as an abnormal or excessive fat accumulation that accumulates and that has an impact on health. Now, there's various tools one can use. The most recognized one, bottom left, is the BMI. And one needs to understand that this is a concept that was actually borrowed from the insurance industry and then was adopted in the field of medicine. Some of the other parameters are just looking at waist circumference, and then you can even look at waist-hip ratios. So if you look at the international classification, that's the first block in blue. Anybody under the BMI of 18.5 is considered underweight. Between 18.5 and 25 is normal. Pre-obesity is between 25 and 30. And then once you're above 30, it's obesity. And then we have various classifications. It's important to note, and especially for this audience, that the Asian population are less fortunate in the sense that we start getting classified as being overweight or obese at a much lower BMI. And by Asians, we mean obviously everybody to the east of the Middle East. So from that perspective, you adopt a tool that you're comfortable with and then stick with it, either BMI, waist circumference, or waist hip ratios. So why should we all be concerned? Well, the truth is, if you look at the prevalence globally of adults with obesity, it is shocking. This is what, the time doesn't matter. What you need to understand is that look at what happens over a period of time to this graph. And as the years go by, the prevalence in every country is on the increase. Now, if you look at South Africa, we're about the 10th country, and we got roughly around 30% of people that are obese. This was in 2016. Here's the global prevalence of obesity. 650 million people live with obesity. 41% of women live with obesity, and that is a figure from South Africa. And if you combine overweight and obesity, it's around 70%. In terms of our males, around 31% of our males live with obesity. So these are worrying figures. And what's even more worrying is that less than 20% of people already recognize that having obesity has had any evidence-based treatment or approach to managing this patient. So we're not even getting to the tip of the iceberg. Now, one of the reasons might be that when you and I manage somebody with blood pressure, we know what organ we're dealing with. You got somebody with asthma, you know what organ we're dealing with. You've got a problem with fatty liver, we know exactly where the issue lies. So what are we trying to manage, and what are we targeting when we're looking at somebody with... So somebody's mic is obviously on, so if you guys can just switch it off. So you and I have always been used to managing the conditions that actually walk in the shadow of obesity. We know about hypertension, we know about diabetes, we know about dyslipidemia, we know about coronary artery disease. But remember, these are all as a result in one way or the other with this epidemic that I'm talking about today, and that's obesity. So if you look at the topic for today, how does obesity impact health? Well, each one of these circles represents a different condition. And to date, there's 229 complications, and it affects every organ system and every subspecialty. Now, the size of the circle represents the impact that obesity has on that condition. And obviously, it was at the time it studies. As studies are going on, we realize that some conditions have been even impacted more than others. And so if you look, the biggest ones there would be hypertension. Right next to it will be NAFLD. Just slightly to the left, coronary artery disease, cardiac failure. Type 2 diabetes is a big circle. On the bottom left, GORD, reflux disease. And then you'll see that cancers are quite high up there as well. So there isn't a subspecialty there that is not affected by it. And so let's look at how obesity impacts on the body system. And you can see from a metabolic perspective, it influences cardiovascular disease and its risk factors. So definitely higher risk of stroke, dyslipidemia, hypertension, coronary artery disease, cardiac failure, and even pulmonary embolus. Definitely type 2 diabetes, 85% of people with type 2 diabetes are highly insulin resistant, and insulin resistance and type 2 definitely walks in the shadow of obesity. And so we need to have an impact at that level to decrease this epidemic as well. In terms of NAFLD, It's become a very big topic. For those of you who do clinical trials, you'll note that a lot of the anti-diabetic drugs are now being investigated for NAFLD and NASH. Gallstone disease, it affects asthma, even fertility. So whether you're talking about male fertility or female fertility, whether you're looking purely at polycystic ovarian syndrome with the basis of insulin resistance, all one way or the other impacted by obesity. One may ask, well, how does it affect male hypogonadism? Well, the more obese an individual is, the visceral fat will then aromatize testosterone into estrogen, and that ratio then messes up libido, fertility, and has a vicious cycle where it's going to cause an increased body percentage fat. But also, once you've got fat, you have low-grade inflammation, and that inflammation suppresses the hypothalamic pituitary testicular axis. And so, in many ways, it impacts fertility. And then, of course, thrombosis. And this was best seen during the COVID epidemic. Gout, which is not only joint pain. I mean, a lot of work in the last 5 years showing how hyperuricemia, one way or the other, has an impact on the cardiovascular system. And, you know, every one of my patients from 2003 had a uric acid level because, yeah, I always felt that it should be part of one of the criteria for the metabolic syndrome. And then not forgetting its impact on cancers. What about mechanical issues? So definitely affects sleep apnea, because what happens is when you put on weight, your neck circumference increases, and that definitely then affects the way one is going to breathe. And the number of sleep apneic episodes will increase, and you know that has an impact on cardiac failure in the long term, and obesity itself. It affects incontinence, affects the gynaes and urologists, chronic lower back pain, and even osteoarthritis. So, and then just general overall physical function. Mentally, big cause of depression and anxiety. So you can see this is just the tip of the iceberg, but one way or the other, it affects every one of you guys in the practice. So the one, I don't think any good came out of COVID, but the one positive aspect for obesity is that obesity was one of the high-risk groups to develop severe illness from COVID in the first wave. So this highlighted to the rest of the world that obesity is more than just cosmetics. Because if it wasn't, then how would it have an impact on morbidity and mortality with COVID? So we knew the elderly in the first wave, and people, we assumed people with immune issues. We definitely knew that patients who were diabetic and hypertensive patients were at higher risk of mortality. And then as the waves progressed, that changed. But the one consistent factor was that obesity was linked to morbidity. And if you look at the hospitalization on the top left graph, hypertension and obesity were the #1 reasons for patients who had COVID that needed hospitalization. If you look at comorbidities, as one gets older, so from the blue, you move to the dark blue and to the brown, you'll see that hypertension and obesity had an impact. And then on the bottom, age and gender adjusted figures, you see that across the line, as the BMI increased, so does the mortality in patients who had COVID and a high BMI. So of course the data is much higher, but at the time when I gave this particular talk, we had a study from South Africa showing around 42,000 individuals admitted with COVID, and at the time the peak hospital admission was about 1,500 a day. What they found is that from a cohort of 27,000 patients, about a third had hypertension, about 30% had diabetes, about 20% had obesity. And so definitely obesity then stood out as a risk factor. It's no longer just a cosmetic issue. So people started working out, well, why might that be? We know obesity has an impact on the respiratory function. I showed you earlier, it has an impact on cardiovascular disease and all its risk factors, on diabetes, on kidney disease, and then it's linked to all the common risk factors as well. And that was at the time put up as a theory to say that's probably why patients who are obese had such a severe course. But here is more convincing data, and it came long before COVID. So in Lancet 2009, this study is showing that if you're sitting with a BMI above 30, so between 30 and 35, your life expectancy is reduced by 3 years. If you have a BMI above 40, it's reduced by 8 to 10 years. Now that might not seem like a lot, but the average age at the time, the people in the study, was in the 50s. And life expectancy, where the study was done, is around 82. So if you do the maths, in the remaining 25 to 30 years of your life, if you lose 3 years, that's quite a bit. If you lose 8 to 10 years, that's about 1/3 of the remaining part of your life. So from that perspective, definitely has an impact. Now, this is a bit of good news. This study showed that weight loss has an impact on obesity-related comorbidities. And yes, all of you guys will be whispering on the background that, my patient weighs 100 kilos. What's the point of losing 5 or 10 kilos? 5 to 10% weight loss from any weight that you're starting off on the left has a reduction in the risk of type 2 diabetes. So not only will it decrease the move from pre-diabetes to type 2 diabetes, but even patients who have type 2 diabetes, you can have about a 50% reduction just in fasting glucose. It's been shown to reduce cardiovascular mortality. On the third block, it has an improvement on the lipid profile, where the total cholesterol can come down as much as 30%. There's an improvement in blood pressure, where depending on which work you're looking at, the systolic blood pressure can drop anything from 10 to 20 millimeters mercury, and diastolic by 4 to 6. While that may not sound like a lot, that's equal to, and if not more, than most antihypertensives on the market. It improves the severity of obstructive sleep apnea and has been shown to decrease the number of episodes per night, and general quality of life, 5 to 10% reduction. So it's important to get your patients motivated, set realistic goals, small baby steps, and then move on. Why do we need pharmacotherapy? So today, although I'm not going to be covering pharmacotherapy because you guys wanted the emphasis on just how does it impact health, the reason why we need it is that, it is not difficult for patients to lose weight. And here's the proof. So if you look at it, just over 15 studies here, and showing you that there is a mean reduction in weight in terms of kilogram, anything from 5, which was the minimum, up to 30 kilogram weight loss in some of the studies. So why are we here? Seems like an easy thing. Problem is, you can get patients to lose weight in a short term, but once you follow these patients up, a lot of that weight loss is regained. And that's the important thing that you and I need to understand, is that just like your patient has accepted that in most cases, hypertension is there for life. In most cases, type 2 diabetes, especially if it's been there for a long period of time, is there for life. And like asthma, you're going to have to manage these patients chronically. Well, obesity is no different. It is not a quick fix. It's a chronic condition, and one needs to always keep an eye on it. I'm going to show you why that is happening. Metabolic adaptation. Remember, what we're trying to fight here is millions and millions of years of clever evolutionary systems. For most of mankind's life, food was a scarcity. It wasn't easily available. There wasn't a Spar and Woolworths around the corner for the last 10,000 years. That's only come in the scene in the last 100 years. So if food was a scarcity, of course, we would have to have systems in place to try and conserve energy, especially when it's needed through a long winter when food is not easily available. Or if a female is pregnant for 9 months, that's going through more than one season. If you have a long winter, how is that female and that offspring going to survive? So these metabolic adaptations were there to protect us in times where food was lean. And so what happens here, if you look at the graph on your left, initially you have weight loss, and then the weight comes back. Why? Because of adaptation to the metabolism, and then adaptation to the whole appetite center as well. So what happens is, sorry, I just messed up there. So what happens is you get somebody to lose weight in any way you can. So here, this study looked at energy restriction, patient loses weight. However, the message that is getting into the person's brain in the hypothalamus, the leptin levels go down. Now, leptin is something that's produced by fat cells, and it's almost like a signal that goes to the brain, always telling it how much fat we've got in store. So as soon as the fat stores go down, leptin levels go down, the brain picks up, there's a problem. Your satiety hormones are going to go down. What is satiety? Satiety is the sensation you feel when you're at a wedding, food is looking good, you quickly eat as much as you can, hoping to get a second round, and then you realize, oh shit, I've eaten too much. That sensation is satiety. In most of us, it comes early. However, in patients with type 2 diabetes, in obese patients, that signal is lost or it comes too late. And it's in response to not having enough food. Because if you were gone hungry for over 10, 15 days, haven't eaten much, you come across a carcass, you come across some food, and you just have a bit of a nibble and you move on, that's problems. So the body is going to make sure it's going to decrease its satiety hormone so you can eat and gorge as much as you want to. Now we see the extremes of this in some of the other animals in the kingdom. That is why a crocodile can eat once every 3 to 6 months. It is why where the GLP molecule came from, the Gila monster, which is not a monster, it's a beautiful lizard, only needs to eat every 6 months. It's because of the satiety hormone. And so what's important is to know that these adaptations were there to protect us. Now, once all these leptin, satiety, hunger signals start changing, your body starts desiring food. It starts looking more attractive. You become more hungry and you start looking for more food. The body, through metabolic pathways, is going to try and conserve energy. One of the examples is that your T4 to T3 conversion is going to go down. It's what we call the hibernation hormones. And slowly, the weight is going to come back. So what the body is doing all the time is trying to defend a particular set point. And once that set point is breached, in other words, if I was 18 years old, my weight was sitting at 65, it will try and defend that weight all the time. But if it's gone up or down for a long period of time, especially gone up, it starts getting used to the 65. When I try and drop it from 65 to 62 the next time, we'll always try and defend the 65. And as we get older, that set point changes in the upward direction, but not in the downward direction. So what are some of the treatment options? Well, it's important to know and look on the bottom, no matter who you're dealing with, thin patient, tall patient, pre-obese, obese patient, it is now recommended by all guidelines that every individual, regardless of body size and competition, will benefit from a healthy lifestyle, from good sleep, regular exercise activity, because all of these, one way or the other, whether by influencing genetics or epigenetics, is going to have an impact on it. I showed you that study in terms of the weight always being regained. Remember, And today's talk is not about pathophysiology, but if you look at the wiring between the body and the hypothalamus, you'll see that addiction, the dopamine reward center, very closely tied to food. And so behavioral modification at every level is important. So if you look at pharmacotherapy, depending on which guidelines you're looking at, if you're sitting with somebody who has got a risk factor like type 2 diabetes or hypertension or dyslipidemia or other comorbid disease, core pulmonale, and you're sitting with a BMI of 27 to 30, you can come in with pharmacotherapy. So it's then lifestyle, behavioral, cognitive therapy, and medical treatment as well. If you're sitting with a BMI above 30 to 35 with no complications, so just weight is an issue, you can come in with pharmacotherapy with behavioral modification and lifestyle as well. And then certainly depending on which guidelines you're looking at and the comorbidities and the complications, surgery is then looked upon as well. So in the past, medical aids never used to pay for metabolic surgery. Now they do. In the beginning, they used to only pay for BMI about 40. Now, depending on the risk factors, why? And they're not keen payers for anything. They've realized that in these high-risk patients, once you do metabolic surgery and you lose about 40 to 60% of the excess weight, in other words, if the person's supposed to weigh 60 and they weigh 120, that's 60 kilograms of extra weight, you're going to be losing 24 to 36 of that kilograms within the first 4 to 6 weeks. And most of it, I mean, if you keep up with cognitive therapy, a dietitian, you're probably able to keep it off. And they've translated that over a 2-year period to be cheaper. It's cheaper to pay $250,000, do the op, than to have the patient move on or continue being diabetic, hypertensive, and all the complications they're going to have to pay for. And so over the years, they've slowly moved from 40 to 35 to 40 with obesity-related complications. And then in some of the countries, above 30, as long as they've tried behavioral therapy and lifestyle and it's failed, they pay for surgery as well. So this is just one algorithm out there, and I like this one. It's a Canadian one. They look at BMI above 30 or BMI above 27 with comorbidities, and then you need to consider one of two things. You move to the left if you've got some of those metabolic parameters that I spoke about earlier, diabetes, prediabetes, hypertension, obstructive sleep apnea, PCOS, then you're looking at either the option of liraglutide as first choice or a combination drugs called naltrexone and bupropion, which is now available in South Africa, Contrave, and then lastly, the option of Orlistat. You can start one at a time, and if you don't get enough weight loss, that is at least 5% weight loss in the first 3 months of using the drug at maximum dose, then you can move on to the second agent or add on. However, if you don't get 5% weight loss, you stop and you move on. And if you tried all three and you're not winning, wait for something else to come up. Or if the person meets criteria, then it's surgery. If, however, you've got a BMI above 30 or BMI above 27 with comorbidities, and there is something that you pick up on history that looks at depression, some form of addiction, then for the craving center here, the naltrexone bupropion combination is first. If you don't succeed with it, then liraglutide. If you don't succeed with that, Orlistat. And again, if it's successful, carry on. If it's not, add on or move on to the next drug. So I've just quickly gone through that, but I'm going to end up with a case study, just showing you that you can have gratifying results, but it's important to have a style to how you're going to be approaching this patient, and know that it's very important to have a multidisciplinary team approach where the exercise is important or the activity, working on dietetics, having some kind of cognitive therapy. And then, of course, your role is one of the most important. So a 40-year-old patient with a BMI of 33.5, male patient who worked as a sales consultant. So from that perspective, why did this person want to lose weight? Well, married with 2 children, high pressure job, frequent travel, and you normally want to engage the patient and ask them, why do you want to lose weight? Each person has their own story. It brings in the more personal touch. And this patient just said, look, I'm a sales consultant. I need to look the role just purely for physical appearances. But obviously, as you dwell deeper into it, the patient's already pre-diabetic, dyslipidemia, anxious, stressful life, hypertension. Okay, the makings for everything you and I see in a patient who's going to end up with something very bad down the line. So whilst the patient may want to lose weight for physical appearance, remember, you're going to be getting some benefit in some of the conditions you're going to be treating as well. And so the end goal is that we all win. The therapy the person was on was a rosuvastatin for the cholesterol, calcium channel blocker, and the patient was put on Puricos for gout. Height, when the patient came to me, was 181 with a weight of 110, BMI 33, blood pressure 130/90 on that amlodipine, cholesterol shocking at 6.9, fasting plasma glucose 6.1, and an HbA1c was 6.2, and the patient was not anemic. So current lifestyle and history, we've got a male patient who's pre-diabetic, hypertensive, dyslipidemic, overweight after getting married, has many weight loss attempts, is very anxious, skips meals, likes to nibble, likes carbo loading. From an activity perspective, walks at least once or twice a week, and basically enjoys life, but doesn't want to go shopping because of not being happy about the weight, not being able to do what he wants to in terms of clothing and whatever he needed. So, and shopping was his passion in the past. So what interventions do we suggest or implement? Well, dietary interventions are very important. Whether between you and your dietetics advisor, you guys are au fait with the DASH diet or Atkins diet or paleo or calorie restrictive diet or just low GI, know your stuff before you make any advice on it or refer the patient on. But the dietetics approach has to be interwoven with your management. Physical activity. So here I tell my patients, you need at least 10,000 steps a day to lose weight. How you get to it doesn't matter. And once you got to goal weight, you need about 7,000 to maintain it. So lifestyle coaching is big and important. So not only on the nutritional side, teaching patients how to shop, how to read labels, behavior around food, physical activity, being aware of the environment they're in, because sometimes certain environments are more conducive to them overeating. Sleep becomes important. We know if you don't have 7 to 8 hours, or if you don't sleep before 10, or if sleep is interrupted, all has an impact on weight. And then, of course, you bring in the pharmacotherapy as well. So it's a comprehensive approach with a talk completely on its own, but this is what we managed to achieve. So at the 6-month visit, the height remained the same, of course. The weight went down from 110 to 98. Fasting glucose came down from a pre-diabetic state to a normal state. Blood pressure on treatment came from 130 down to 118. And so gratifying results, we continue the patient's treatment. Now, this is what some of you might be thinking about. Is managing a patient living with obesity that simple? No. But one of the biggest hurdles you need to overcome is your bias. And so while it seems like I'm attacking you, there's been a lot of work, the IO action study, which took physicians all over the world and found that we all have a bias. So there might be many reasons for it, but you and I on a daily basis, we write out scripts for hypertension. There's a way to define it. There's a class of drugs we prescribe. You got patients with diabetes, type 1, type 2, gestational pancreatic. There's drugs for it. You prescribe it. You tell the patient, go and measure your sugar levels, get a diary, watch your diet. You look at the H1C and you make adjustment. Somebody gets a heart attack. Somebody puts a stent in it. They tell you, look after the aspirin, statin, blood pressure for me, and then you refer the patient annually to a cardiologist. So we're comfortable doing that. However, we're not comfortable asking our patients about their weight issues. And here's a fact. From the same study, they looked at what the patient's perspective was. The patient believes it is completely his responsibility to manage weight, and is even scared to ask you. This is in most of the cases. What is the doctor thinking without verbalizing as the patient walks in and seems like they're overweight, obese? He's not even interested in losing weight. That's what 71% of us are thinking. And yet only 7% of people living with obesity are not interested in losing weight. So that other 93 is not finding a way to talk about the weight issue with you. So you know your patient best. You need to find a way of bringing this topic up, either directly or indirectly, to say, hey, Mr. Musa, we know you've got type 2 diabetes. Here's your results. One way we can impact it is to look at weight. There's a study showing that if your weight comes down by 10%, glucose is going to improve beta cell recoupment. So you need to find a way of engaging the patient. It might be an elderly grandfather who comes in 73 with 3 grandkids, and you've got kids, to say, hey, this work's showing your level of activity and mobility will improve if we get you to lose 5 or 10% of the weight, and you're able to spend more time with your kids. Make it engaging. Make it personal. Leave guilt out. Try and work your bias out of the equation. And if you don't engage the patient, that's why only 20% of obese patients have had some form of treatment offered. So the reason why I'm employing and spending time on the slide is that the time from weight struggle to healthcare practitioner discussing it is almost 6 years. So on average, most people will have a weight issue by 33 years, and that was in this study. They would have had 4 failed attempts by themselves buying legal or illegal things from the chemist, and that 6-year gap is what you're going to need before you engage the patient with a discussion. So make it simple, guys. Have this nexus with your patients early, and we will all benefit from it. So I'm going to leave it there. I was asked to speak for 40 minutes, and I think it's exactly 40 minutes now. And I've got another meeting at 8 o'clock. So please put your questions into the chat box and we'll chat. So I'll see AK says, please comment on intermittent fasting with regards to weight loss. Excellent. What's my proof? Well, for thousands of years, there wasn't a fridge. So most of us only had one meal. And so your body is wired that way. And so, yeah, and the other reason why intermittent fasting, I think, is important is that it allows your body to adapt easily between ketosis and living off glucose. And that metabolic switch is very important. So certainly, I encourage it. I used to have reactive hypoglycemia, and people used to know on the ward round, if I haven't eaten, even as a student, as an MO, I become edgy, irritable. So I used to always carry food around. Now, both my wife and I, 5 days of the week, and if you guys see us, we thin as sticks. So we didn't need to do this for weight, but just from a health perspective, 5 days of the week, we have lunch and supper within a 5-hour period, and the rest of the time, nothing. And I can tell you, I've got a lot more energy. And so definitely works for us, but you got to try and tailor make it to your patient. And so get them to start saying breakfast. Ideally, what you want to be doing is having breakfast and lunch and skip supper. That is a bit more difficult, but you can start by saying, move the meal out by an hour and slowly condense the 2 meals together, and it becomes easier. Shamala Adam wants to ask everybody, is keto diet advisable? Yeah, definitely. So what do you think the diet for type 1 children were before 1912, before first insulin was invented? That child died. You had a child in the 1800s with type 1 diabetes, it's game over. Unless you asked your patient to go onto a ketogenic diet. And so it was completely off carbs and the child survived. Wasn't obese, was thin and puny, but survived. So ketogenic diets, you think the lion wakes up one morning and goes and have a mealie? They don't eat any carbs at all. And so keto is fine. But what I notice is that with some people, with ketogenic diet, the cholesterols go up, and in other patients, the cholesterol goes down. So it's actually a metabolic adaptation that is different from one person to the other. So I believe in tailor-making treatment to your patient, and you need to work around what works for your patient. Rashid wants to ask, can a drug like Victoza be used in a non-diabetic only for weight loss? Of course. Remember, Victoza is liraglutide. It's available in 0.6, 1.2, and 1.8 milligrams. So its side effect initially is a bit of nausea, bloating, loose stools. So you start off low and every week build it up. Now, Saxenda is liraglutide at a higher dose, 3 milligrams, registered for obesity. So we've got a registered drug in South Africa called liraglutide, 3 milligrams, and it's used for obese patients, and they don't have to be diabetic. What kind of weight loss you got? So on another day, maybe we'll talk about pathophysiology, and that leads into how the drug works and what kind of percentages you're looking at and what you need to do to maintain it. It's a talk on its own. But today's scene, I think they just wanted me to tell you how it has an impact, but definitely it can be used. Zara wants to know, would you recommend any herbal or natural supplements for weight loss, obesity, and if so, which one? So I've always used a product made by Organic Remedies called Glucose Stabilizer, and because it has 6 items in it. So, you know, I remember a few endos used to laugh at me because my patients used to tell me when they used to find out that they had my patients on cinnamon. Now I'm busy with the South African guidelines, and you know, in some of the meta-analysis, somebody did a whole meta-analysis on studies with cinnamon and HbA1c. Okay, it's not a registered drug, but the results from the systematic review look good. So this product has cinnamon, it's got chromium, which helps second message receptor function in terms of the beta cell. It's got manna, which is guar, shown in
Sorry, Dr. Bana, I think you've muted there temporarily.
Yeah, okay, so I've unmuted. So yeah, I use a product called Glucose Stabilizer by Organic Remedies. How about appetite suppressants, Duramine? So remember, as of the 70s, there were a lot of drugs for weight loss, and all of them left the market because they've been shown to increase cardiovascular mortality or have pulmonary hypertension or valvular heart lesions. And so as of a few years ago, the FDA and a lot of other health authorities said no diabetic drug or no obesity drug would be registered unless they show cardiovascular safety. So remember, Duramine's been long on the market. It is an appetite suppressant. My belief is that it's not working to the core cause of the problem. But remember, the company that makes it tells you it cannot be used more than 3 to 4 months. And I just told you this is a chronic condition. So typically what my patient tells me when they've been on Duramine in the past, that it's excellent for weight loss. Let me give you an example, Dr. Mudli. Patient comes to you 80 kilograms. Now, bear with me and remember the figures now. 80 kilograms and their waist size is 38. They go on Duramine. They get to a weight 60 kilograms and their size drops from 38 to, let's say, 32. After a while, the weight comes back on. They go back from 60 to 80, but this size is no longer 38, it goes to 40. Go on another course of Duramine. The weight drops back from 80 to 60. Slowly the weight comes back, it goes back to around 80. But now the size is 44. So what happens with Duramine is that you also not only lose fat, but you lose muscle. And guess what? What's easier to put on? Muscle or fat? And 1 kilogram, so the amount of space 1 kilogram of fat occupies compared to 1 kilogram of muscle is 6 times the volume. So in the long term, that's not a solution. Besides the side effects of sweating, palpitation, anxiety is too much. Does dulaglutide show similar weight loss to liraglutide? So these are excellent questions. And dulaglutide is a long-acting GLP molecule, a once a week. Liraglutide is a daily dose. And then the semaglutide, which BP is another once a week injectable. And basically, I think dulaglutide has better results than 1.8 milligrams of liraglutide, but not as good as the 3 milligrams. But remember, it's an individual thing. You've got to tailor make it to the patient's treatment. Some people don't mind having an injection once a day. Some people don't mind having it once a week. Some people forget once a week and they want it. So tailor make it. And basically, you're looking at between 9 to 12% weight loss over a 12 to 16 week period. Then I think I missed some questions here. Please speak about inflammation as related to diet, obesity, and general impact on the body. So yeah, yesterday we had a masterclass, Govind Sami, the third masterclass Nova hosted on obesity. And then the dietitian spoke about foods that are anti-inflammatory, because modern foods are very inflammatory, and low-grade inflammation speaks to obesity, speaks to type 2 diabetes, speaks to an atherogenic LDL molecule. So inflammation, very important. What's your opinion on gastric bypass surgery in treating obesity? Okay, Mohammed, I think maybe you came in on quite late, but I had a whole slide to show that there is a role for gastric bypass. In fact, medical aids pay for it under certain criteria, and all the organizations world over dealing with obesity also approve of it in the right setting. These patients are expected to lose about 10% of their weight to decrease anesthetic risk. They're supposed to make sure that they keep following on with a dietitian and a psychotherapist. And then, yeah, you've got one of 4 different surgeries to have an effect on weight loss. Of the drugs mentioned, which are safe for using during pregnancy? None. Can obesity be treated medically during pregnancy? No, guys, don't mess with pregnancy. Remember, no, just wait for after pregnancy. A lot of drugs have not been tried in pregnancy, and certainly that's the wrong time to get the patient to lose weight. You're supposed to get the patient to lose weight, Miriam, before they fall pregnant. And so if the patient's diabetic, pre-diabetic, or had PCOS, the gynae may opt, and I think it's an excellent idea, to continue with metformin throughout the pregnancy to help maintain the weight. So certainly none of these drugs are registered for use in pregnancy. Let me see if I can cover a few more. Your opinion about protein shakes as meal substitute? Of course. So, but remember, choose your protein shake carefully. Look at the carb content, look at the sugar content, because it tastes like hell. So they have to make it a bit more palatable. And then they end up putting sugar-like substitutes. So remember, sugar is not good, but the lesser of the devil is a sugar substitute, but it's not completely innocent. These sweeteners have been shown to affect the gut microbiome, which influences weight as well. So I'm happy with protein shakes as long as they read labels and they make sure that the sugar content is kept to a minimum. Now, I don't know what happened there. Am I still around?
You're still on, Dr. Bana. I think
Okay.
there's just one or two more questions. I don't know if you still have time.
When will obesity be classified as a chronic condition by medical aids? An appropriate registered medicine be paid for? Okay. So, Shanaz, that's your job and my job. As we manage these patients, and that's how they did it in Canada. In Canada, they pay for this. In the UK, they pay for this. In New Zealand, they pay for this. What we need to be doing is that all of us here, and I see there's over 150 of you, if you guys get data on what the blood pressure was, what the HbA1c was, what the cholesterol level was like, what's the BMI at the start of your weight loss program and at the end of your weight loss program, all of that data gets collated. Then you can turn around, publish that work and say, for the first 1,000 patients that were treated by doctors at IMASA, average HbA1c was like this. This is what happened at 6 months. That's when you can convince the medical aids to say, brother, sister, you better come in and start paying for these drugs. And that's how it's worked in the other countries. And so that's why it's important for you to make sure that we're all collecting this data. And we are going to be starting an obesity society. And I think it needs everybody involved because you can see it affects every subspecialty. And this body will then move on to start helping collate all the data. And last one, how does BCAA help in losing weight? So it does. Maybe let me leave that for another day when we're talking about pharmacotherapy. And if you guys want, I'll put up a few case studies and treatment. So these short-chain amino acid, branched amino acids and fat molecules, and there are other fat molecules as well, decreases inflammation. It does wonders to insulin-glucagon ratios. It improves the functioning of hormone lipase. Yeah, that's a talk on its own. But I think its biggest benefit, Safia, is that it improves the gut microbiome. All right, so I've got 2 minutes to get on to my next meeting. I thank you very much for inviting me over. I see it's a massive audience, so kudos to whoever's running the society, because over the last 3 years, people are getting tired of online and people are even getting tired of going to meetings. So seems like whoever the organizers are here are doing a damn good job. Well done. Take care, and I bid you well.
Thank you, Dr. Bana, for taking the time and for really an excellent presentation. I think you've covered a lot in a very short period of time. We're not going to keep you too long, but we hope to invite you back. I see there's a lot of follow-up talks from this. I think the next one should be the pharmacotherapy talk. But thank you again for a brilliant presentation.
All right. Take care, my dear. And you guys as well. Bye.
Bye. All right. So to everyone here, thank you so much for attending. We're just going to introduce the next few web IMAs before you leave, please. So the next one is more or less a follow-up on this talk, a similar theme. It's entitled Weighing In on the Brain. So yes, also about obesity, but our focus here is going to be more on the mental health effects of obesity and how it affects patients. And then the next IMA after that, Kashifa, the one after that, please. Okay, and then the next one will be on the 14th of September, I think. Sorry, I'm just waiting for that one. Yeah, 14th of September. And this is by Dr. K. Mohammed on new ARVs, new trials, and a new way of approaching.
Well, it can't be only for IMA members.
Sorry. So if you have any questions, please put it on the chat. Thank you for all the positive feedback, everybody. Kashifa, I'm not sure about the recordings being available. Maybe you can comment on that quickly.
Yeah, all the web IMAs are recorded and it is uploaded onto our YouTube channel. So I'll send a link out to everybody.
Yeah, please follow the IMA on social media. You'll get more information about all the upcoming web IMAs, links to the YouTube channel, etc. And then the last thing that I want to just draw everyone's attention to is that the IMA convention is taking place in Durban this year. Also promises to be a very interesting program. The theme is 40 and forward, and we do invite submissions and abstracts. Please take note of the details that are currently on the screen. It will be taking place from the 1st to the 2nd of October at the Coastlands Hotel in Durban. So anybody that's got a presentation or a poster that they'd be interested in, please take note of that. As far as proof of attendance of these seminars, this is registered for the CPD points, which do get submitted and should be uploaded automatically. You can welcome to email us should you require anything else from a administrative point of view. Okay, so I think just on time, if there aren't any more questions. So just a reminder, please do follow the IMA for subsequent talks. And remember the future web IMAs as well as the mini symposium that's taking place in August. Thank you everybody for attending. Have a good evening. And assalamu alaikum wa rahmatullah. Peace and blessings be upon you all.
Thank you for an excellent presentation. Good evening.
Thank you.
It's a pleasure, everybody.
Thank you.
Yes.